bachelor's in zoology at the University of Washington in Seattle, as well as his medical degree. He did his postgraduate training at Harvard and Brigham and Women's Hospital in Boston, and his postdoctoral basic research fellow was completed at Dana-Farber. Currently, he is the Clinical Trials Core Director of the GU Medical Oncology Research Group at Fred Hutch. He is also the Medical Director of the Clinical Research Support Group. He has over 100 publications and is the Senior and Associate Editor of Clinical GU Cancer, Euro Today, and Clinical Cancer Research. And today, Dr. Yu is going to be speaking on updates in the management of prostate cancer.
Thanks so much for that kind introduction. It's a real pleasure to be here today. I've been here, this I think is my 4th year here, and so it's always wonderful to be out here. The weather's always nice, the lake's always beautiful. All right, let's find my slides here. And there I am. So used to using it back, I have to think about how to do this here slideshow from the beginning. All right, so I'm going to talk about prostate cancer today, and I was telling Renee yesterday that I'm really pleased with the fact that I've been here the last 4 years, but I've looked at my talks every single year, and they've evolved quite a bit. That means there's enough changing in prostate cancer that I don't have to talk about the same thing over and over again. So that's pretty exciting. But I'm going to talk about some of the newer agents, some data from ASCO, and incorporate some clinical case discussions in there. Now, my understanding is that you guys are able to enter in choices of mine. Great. So here are my disclosures, and of course I'll be talking about some non-FDA approved products as well in this discussion. I want to focus on some areas that I think are pretty hot right now. We all know that there are many new agents for metastatic castration-sensitive disease with abiraterone, docetaxel, leading to dramatic survival benefit, but selection between those agents is uncertain. As Axel earlier talked about microsatellite instability in colon cancer and other GI malignancies, it's something that happens in prostate cancer as well. He alluded to that. There's increasing data that MSI high and hypermutated prostate cancer is a real thing, and that these patients might respond well to certain immuno-oncology agents. We're getting more and more next-generation sequencing, and I think most of you have heard about the fact that DNA repair abnormalities are not just in breast and ovarian cancer, but it's a big deal in prostate cancer as well, so I'll talk about that. And obviously the newest FDA approvals are in the M0 castration-resistant prostate cancer space, so I'll talk about that as well. So this is the first case. This is a 68-year-old gentleman who has low back pain and presents to his primary care physician's office. He does eventually undergo a CT and bone scan imaging, and it confirms that there are 5 osteoblastic lesions in the thoracic and lumbar spine, multiple 2 to 3 centimeter pelvic, iliac, periaortic lymph nodes, and his PSA is checked and it's 52. So he undergoes an MRI and he doesn't have a spinal cord compression. So what do you treat this patient with? New metastatic, hormone-sensitive or castration-sensitive, hormone-naive, whatever you want to call it, prostate cancer. What do you do for this patient? Whoa. That's not what was supposed to come up, but, oh, okay, I guess it was changed. This is not what I expected. But one option is an LHRH agonist alone. Option B is bicalutamide, then an LHRH agonist. Bicalutamide is first, followed by LHRH agonist, 6 cycles of docetaxel, abiraterone, prednisone with an LHRH agonist. And it looks like people are responding. Let's go 10-15 seconds or so, see how the numbers change. That's interesting. Somebody throw me throw me a bone here. All right, well, let's go ahead. Here's what I would do, is I would do D, and here's the reason. I tried. Here's the reason why. Let's rewind to this case. He has 5 osteoblastic lesions and multiple lymph nodes. So this comes down to the fact, actually I have data slides, so I'll just go ahead. So let's start first with docetaxel and dissect that data. We know the charted data in the United States shows a dramatic survival benefit for docetaxel chemotherapy. And if you take all comers with metastatic disease, it looks like it's about 13-month median survival benefit. But let's break it on down. And if you break it down by subgroups, which I always tell you not to focus too much on subgroup analyses, but we seem to, the overall survival benefit was greater for those with high volume disease. Now, what was high volume disease? This was established from old studies. Like in 1990, there was a New England Journal flutamide study where they made it in the New England Journal not because flutamide was such a dramatically great agent, but because they broke down prognostic criteria based on location of metastases. This would never make it in the New England Journal now, but back then it was acceptable. And what they found is that you have 4 or more bone metastases with at least one outside of the axial skeleton, appendicular skeleton, let's say humerus, femur, ribs, etc., that all counts, that those patients had a worse prognosis, higher volume, higher risk disease. Or if you had visceral metastases, obviously, if you have liver metastases, lung metastases, those patients are at higher risk. In that patient population, the survival benefit is more dramatic. It looks like it's about almost an 18-month survival benefit, which is quite impressive at median for any oncologic studies or drugs. But for the low-volume disease population, the final analysis, which certainly could have been underpowered, showed no difference whatsoever between those that received ADT and those that received ADT with docetaxel. So in the United States, we tend to lean towards treating those with docetaxel with high volume disease. Now remember, this patient, 5 bone mets, all in the axial skeleton. So I tried to trick you a little bit, nothing in the appendicular skeleton at all. So this wouldn't be an ideal patient to get treated as if they had high volume disease with docetaxel. Lymph node metastases are considered good risk, good prognosis, low volume disease. Okay, then there was a Stampede trial in the UK. They didn't break down high volume, low volume disease, but they had a heterogeneous population where they had M0 patients. They had patients who had biochemical recurrence with short PSA doubling times, lymph node positive disease only, found at surgery. They had patients with high-risk features, but they showed a survival benefit as well, median survival benefit about 10 months when you take that patient population. But 61% of the patients did have metastatic disease, and of course the survival benefit was generated by those patients who had metastatic disease. As you see, the median survival benefit is more dramatic in this patient population that has more advanced metastatic disease. So if you look at some meta-analyses, forest plots here, you can see that with docetaxel, it falls clearly to the left, but really the benefit is driven by those with metastatic disease, okay, not by those with non-metastatic M0 disease. So that's an important thing to notate, that if you see the middle of that forest plot there for M0, it falls right on the hazard ratio of 1. All right, now more recently we have the Latitude trial. This was also performed in Europe, and we see that adding androgen deprivation therapy, adding abiraterone to it, leads to a survival benefit as well. And in the Latitude trial, they took patients with metastatic disease, but they had different criteria. They said you had to have 2 of 3 high-risk criteria, either Gleason 8 or more, or 3 or more bone metastases found on bone scan, or measurable visceral lesions. And so if you had 2 out of those 3 criteria, you could be eligible. By my rough estimates, that's probably about 80% of patients who have metastatic prostate cancer. Okay, so most people were probably eligible who have metastatic prostate cancer. There was, of course, also a UK arm in the Stampede trial with abiraterone, and this also showed a survival benefit as well. The one unique feature to this arm is that it was almost a split 50-50, slightly more patients with metastatic disease, but many of the patients were M0, okay? So this is a little bit interesting. This forest plot's a little bit different. They don't draw the line there on 1, but you can see that for the M1 population in the Stampede trial, very far to the left, clear survival benefit using abiraterone and prednisone here. But for the M0 population, still the 95% confidence interval crosses 1. But the nice little box in the middle is still pretty far to the left of 1, and it barely crosses 1. So I have this kind of extrapolation. It's not perfect science here, but I'm going to say that If it's close, and the biostatistician would probably crucify me for saying all this, but if it's close for an entire M0 population that doesn't even have metastases, that if a low volume, you took this and broke it down to the low volume metastatic disease patients, it's probably statistically significant, okay? Not any clear science behind this. There's no data to show what's right or wrong between abiraterone and docetaxel. But if I had a high volume disease patient, you could give either. If I have a low volume disease patient, I think the data gives better implications towards abiraterone for low volume disease patients because there's almost a statistically significant benefit for those that don't even have metastases. So I'd rather treat a low volume patient with abiraterone. Of course, they did this direct non-randomized comparison. There was not a pre-specified analysis from Stampede since they had an abiraterone and they had a docetaxel arm. And of course, they showed no difference because it was not statistically powered initially to show a difference. So this doesn't help us at all in terms of efficacy, but they had to do the analysis because people asked for them to do the analysis. These are real practical comparisons. Again, if I have a low volume disease patient, I'm going to recommend abiraterone. But if I have a high volume disease patient, I'm going to talk to them about either or. And I'm going to talk to them about the differences. Docetaxel, limited duration of therapy, 18 weeks, 6 cycles, 6 IV doses. Whereas abiraterone, you're taking it potentially for years, daily therapy. For docetaxel, certainly lower cost, both for the healthcare system and also for patient copays, since IV therapy is covered well in this country and oral therapy is not so well. So there are practical, pragmatic cost differences there. Probably higher toxicities for docetaxel, not terrible, and lower toxicities for abiraterone. But you know, the comorbidities and toxicities, side effect profiles, patient preference, they become